Hello, I'm Jean Pete, and I welcome you back to our show, Better Living. Better Living is brought to you by the Homestead Hope Foundation and is sponsored by Homestead Hospice, where commitment to education and premier hospice care helps patients and families through life's most important journey. Thank you for joining us again today. We have another great show in store with Dr. Lisa Culpepper, family practitioner. And since it's National Women's Health Month, we have a lot to talk about. We're going to talk about cardiovascular health, breast cancer screening, bone health, new guidelines on cervical cancer screening, menopause, and maybe much more if we don't run out of time. So get your pen and paper and get ready to learn about women's health. Again, I'm Jeannie Pete. Welcome back, and I'm here with my co-host, Allison Finley. Allison, how are you doing today?
I'm great, Jean. How are you?
Good. Excited for the show today.
I am too.
Dr. Culpepper, welcome. Thank you for joining us.
Thank you for asking me.
So, May is National Women's Health Month.
Yes.
So can we talk a little bit about what you see as most important in terms of women's health?
Well, when we're thinking about women's health, of course, obviously there's a lot of focus on breast cancer. That's what we hear about all the time. And obviously, that is very important. But the number one cause of death in women is actually cardiovascular disease.
And that's true because I think, we've done a great job at advertising the need for mammograms and breast screening. Mm-hmm. And here in Atlanta, we've got the Susan G. Komen, which is very big. And so kudos because we're getting the word out. But really, we need to pay as much attention to our cardiovascular health as we do in the screenings for breast cancer and all, because as you mentioned, it is the number one killer of women.
Yeah, absolutely. I mean, 1 in 2 women will have a cardiovascular illness and 1 in 3 will die of it. So, and the most important aspect of that care would be prevention of cardiovascular disease. And there are very, different things that go into ideal cardiovascular health. That's checking your cholesterol, making sure that it stays less than 200. That's checking fasting blood sugar, making sure it's less than 100. It's not smoking. They recommend moderate exercise, 150 minutes a week. It sounds like a lot. It probably is a lot to a lot of us women out there working and taking care of our families, but taking care of our homes. But if you can divide it into 30 minutes 5 times a week, it is doable.
That's really not bad. Now, let's get back to something that you said about cardiovascular health. 1 in 2 women are diagnosed and 1 in 3 die? Mm-hmm. Did I hear you right?
1 in 2, and that can be cardiovascular disease. That's coronary artery disease that causes heart attacks. That's congestive heart failure. That's high blood pressure, of course, diabetes. I mean, that itself is a vascular disease because it affects all the blood vessels in our body. Peripheral vascular disease, where women have blockages in their legs.
Now, do we have an age? What is the typical age where we're seeing this in women? Is it getting younger and younger, or do we not have to worry till our older years?
Well, I do think that we're starting to see cardiovascular diseases at a younger age just because of the rising rate of obesity.
That's true.
That is a huge national health concern, and we do see that there's more physical inactivity. Our diets aren't as rich in those fruits and vegetables and high fiber and low fat that we need. That's good for our heart health.
Allison, it always comes down to those fruits and vegetables, healthy eating and exercise.
I know.
Every show I
do. and then that exercise thing. Darn it.
Yes.
Can I just briefly...
No, you can't ask. You're just the co-host in the background. Teasing.
The congestive heart failure thing. I understand blockage of the arteries in your heart. I understand diabetes. I understand everything else that you've listed. But I hear the term congestive heart failure, and I'm not exactly sure that I can verbalize what that is or I understand what that is. Can you give me layman's terms?
It basically means that the heart muscle is not functioning as well. It's not pumping the blood to the rest of the body as well as it should. And obviously, that is the main job of the heart, is to pump the blood to all our organs so that they can function well. And congestive, the heart starts to fail when it has so many blockages from coronary artery disease. That's usually the end point from blockages from coronary artery disease that have damaged the heart muscle so bad that it can't pump, or women who have uncontrolled high blood pressure. They're not treating their blood pressure. Well, that blood pressure that's high causes the heart muscle to stiffen up. And when that happens, it doesn't function as well.
And we don't see symptoms, do we?
A lot of times we don't see symptoms until we actually go into an episode of heart failure.
Yeah.
Or we become swollen and short of breath. And we do have a lot better treatments for it nowadays. We're so lucky. I mean, my dad died at 52 from congestive heart failure.
Wow.
And
that's young.
That is young, and that's why cardiovascular health is near and dear to my heart. But no pun intended there. No pun intended there.
I was waiting for that.
But it is. We have a lot better treatments for it than we used to. But still, if we can prevent that.
So let's talk a little bit about your dad. Did he have any symptoms? Did he know that he had high blood pressure or heart disease?
He
or
did.
Was this a shocker?
He was the typical patient that I see in the office that I do everything I can to prevent them from dying at 52. I mean, he had high blood pressure. He had high cholesterol. He smoked. He ran a mortgage company, which is probably not as stressful then as it is now. But there was a lot of stress. He wasn't exercising. He wasn't eating well, and he went into heart failure. And
my goodness! Now, does that run in? Is that hereditary? Does he have a pattern of that in his family?
There is a lot of heart disease in his family. Of course, there were a lot of smokers. So, and smoking is. If you take someone who smokes compared to someone who doesn't smoke, that person who smokes, I mean, they have a 50% chance of dying prematurely.
50%.
I mean, if that isn't enough to get you to stop smoking, I don't know what is.
Well, especially if you have a family history where the folks in your family are dying early of heart disease or a heart attack, sudden heart attack, don't be smoking.
Yeah.
Yeah, and exercise and do what you can to control, because we could have you around for a much longer time if you could just do things differently.
Absolutely.
Okay.
And I try to remind patients of, you want to see, you want to give your daughter away at her wedding, and you want to see the college graduations. You want to be around for grandchildren and things like that. So
now let's talk about the high blood pressure, because I do have a friend. I always seem to have a friend.
I do too, and I wonder if they're listening and they hear me talking about them.
But mid-40s, late 40s, and couldn't get the high blood pressure under control. We work in healthcare, we work in hospice, so we take the weight of the world and our patients on our shoulders.
Absolutely.
But they really struggled to get that blood pressure under control. What are some things? And again, we all need to exercise more and eat more healthy. But what happens if you're taking medicine and it's still not coming down?
Well, that, can definitely be a problem. I mean, we have a lot of great blood pressure medicines out there, but, we still don't have a complete understanding of the changes that occur at the level of the blood vessel, the level of the kidney, that actually kind of turn on high blood pressure. And that's why we have a lot of different medicines that work in a lot of different ways to try to get blood pressure under control. And, the reason why it's most important to get blood pressure under control is because, we talked about heart disease being the number one killer for women. Stroke is the number 3 behind cancer.
Lord.
And high blood pressure is the biggest risk factor for having a stroke. That's huge for women.
Which can be compliant with your medications, because
Yes.
that's a whole nother problem.
Absolutely. I mean, the patients that I've had who've had strokes, almost every single one of them had stopped taking their blood pressure medicine.
Okay, and there's just no need
They just
for
weren't
that.
taking it, and their blood pressure went up so high, they had a stroke.
And is blood pressure medicine expensive?
Most of the time it's not. I mean,
Okay.
there are very good generics out there. We use the ACE inhibitor lisinopril a lot. I mean, you can get that free at Publix.
Okay.
Of course, everybody's going to have different side effects, or they're not going to tolerate, or it's not going to work. And, we do take into account if a patient is African American. We know that there are better medicines for them that work better in them than work better in white Americans. There are some medicines that seem to work better in men than women. But overall, no. I mean, a lot of the blood pressure medicines that are out, they're not expensive. You can get them on the $4 list at Kroger, and they work just as well as a lot of the newer medicines.
So, folks, the show is called Better Living. And we're here to enhance your life so that you can live life to its fullest for as long as possible. And, I see this because I have worked in hospice and in healthcare for a long time, and I actually know a stubborn my dad, and you don't take the medicine when you're supposed to take it because you feel like, oh, I'm healthy, I don't need it.
Most people don't feel it. That's why they call it the silent killer.
But you know what? It's a pill a day. And it's not expensive, and you owe it to your children and grandchildren and yourself to just take your medicine and be compliant and live better.
Absolutely.
So thank you. Now, I do want to talk, too, about women and heart disease and heart attacks, specifically because it's National Women's Health Month. I've heard briefly that the buildup in the women's system, it builds up along the lining, so it's harder to find, or sometimes they have symptoms, but it doesn't show up on tests. Is that correct? Because I had heard it's easier to diagnose in men than women. Is that correct, or am I wrong?
Well, you are correct that, women do tend to have more atypical symptoms for angina or blockage to the heart. Instead of chest pain, we might have stomach pain.
Okay.
We might have just nausea. And those are kind of non-specific symptoms. So
Which
if a
is
woman
why
comes
they're
in with stomach
ignored.
pain and nausea, we might think, oh, well, maybe you have an ulcer or it's your gallbladder or, I think still overall most women have the more typical symptoms of shortness of breath or coronary artery disease, but you're exactly correct. You can have buildup of that cholesterol, platelet, calcium plaque in your arteries for years before you start to have symptoms. So, there's no hard and fast guidelines for, well, when do you send a woman for a stress test?
And is that the first order of business if you suspect cardiovascular disease? Stress test?
Absolutely.
Okay.
We'll do a screening EKG in the office. Sometimes that will show some blockage or abnormal heart rate, but the next test would be an exercise stress test where we put the heart under stress because that's the most likely time when your heart needs more oxygen during that time. So if there's a blockage there, we should see changes of that.
And I've had that test. I don't know if anybody else has had this. I was in the middle of an EKG during my annual physical, and it simply flat out looked like I was having a heart attack. And we pulled up my EKG from the previous year, and they were clearly different. It literally looked like I was having a heart attack. So I did go to a cardiologist who did do the whole stress test, the whole echocardiogram thing, and there was nothing wrong. And he said, go back over any medications you were taking at the time. And what it turned out to be was I was dehydrated. And dehydration can cause you to throw an EKG that looks like a heart attack. But because the symptoms are so silent, it's easy to ignore them. And when they do happen, like Dr. Culpepper said, they're so vague. I have a friend who has not been to have a physical exam in 20 years, and she's in her early 40s. And I said, "Are you out of your mind?" She said, "Well, first of all, I don't feel bad, and secondly, I'm a little afraid of what they might find at this point." It's just like you can bury your head in the sand for only so long, and then you've got to go. She doesn't want to go. She doesn't want to know now. She's waited too long. The longer you wait, it doesn't get better. It gets worse.
Well, and again, you have a responsibility to your children and your grandchildren and your family and to yourself.
I know.
And so please don't be neglectful, and it's just an exam.
Yeah, the keystone to cardiovascular health, your heart health, is prevention. There's some things that we can prevent and some things we can't. Some risk factors, they're just there. But there are so many things that we can do to prevent getting heart disease.
Now let's talk about high blood pressure.
Sure.
So what are some of the symptoms of high blood pressure so we can get that under control to try to prevent heart disease in the future?
Well, as we, talked about, a lot of times there are no symptoms. So I think the main thing is that you need to go to your doctor. You need to have a periodic health exam where they check your blood pressure. We consider a person to have high blood pressure when they've come in 3 times with 140 over 90. So, I mean, the biggest thing with high blood pressure is to screen, because a lot of times there aren't symptoms. I mean, some people will get, when their blood pressure goes up, they'll get severe headaches. They might get some blurry vision. They might get flushing. They could have even just a general feeling of irritability.
Gee, that covers me on a lot there.
And it's easy to get your blood pressure checked. I mean, that you have free blood pressure checks all over the place at all the health fairs and what have you.
Yeah.
So there's really no need. Okay, Dr. Culpepper, we went right into women's health, and I didn't even mention who you are, where you are. So let's back up for just a minute and introduce you formally. So you're Dr. Lisa Culpepper, and where is your office located? You're a family practitioner.
Yes, I am a family physician. I have been at North Chattahoochee Family Physicians. We're on Johns Creek Parkway, at the corner of Johns Creek Parkway and 141. I've been there for 11 years now.
Very good. And if someone wanted to get in touch with you, what's your phone number to your office?
I can be contacted at 770-497-1555.
Okay.
Can we move into bone health?
Yeah, because we definitely don't want to ignore our bones and, of course, our breast cancer screening.
I know it. I have a mom who's, has been on pills for her bone degeneration for many, many years. And I've heard so many pros and cons over being on drugs like that long term.
Yes, there have been more recent studies which show that long-term use of the most common use of, most common medication that we use in osteoporosis, the bisphosphonates, like your Fosamax, Boniva, Actonel, that over 5 years, it actually may do more harm than good. But we do still think that there is benefit in those first 5 years as far as building bone in the spine and in the hips. I mean, we reach our peak bone mass at 30. That's kind of when our bones are, they're at their most awesome. And between 30 and menopause, not too much change in the bones, but definitely as we go into the menopausal transition and we stop having periods and our production of estrogen and progesterone goes down, the most rapid bone loss we have is in those first few years after menopause. And it's been shown that, women who have low calcium, low vitamin D intake, that definitely can speed up their bone loss.
So if you can only take this medicine for 5 years, where do you go from there?
Well, for a lot of women, if they can take the medicine if they need it, during that time of kind of maximum bone loss, or when they get diagnosed, and there is a lot of controversy over when to start bone density screenings. I mean, if you look at most of the guidelines, they say don't screen for bone density, don't screen for osteoporosis till 65.
What?
Or if there are risk factors between 60 and 65. I don't know that I quite agree with that, because I feel like, well, if the maximum bone loss is within the first few years after menopause, don't you want to try to catch those women early so you can start putting in, even if they're not in osteoporosis, if they're in osteopenia, which is kind of, bone loss before osteoporosis, pre-osteoporosis, you can make lifestyle interventions then. And you also know that, this is a patient at higher risk. I need to keep an eye on her. And if most women who are on, if we put them on a bisphosphonate, they will have an improvement in their bone density. If, at the 5-year mark, they're still not where they need to be, or you keep checking their bone densities and you see it looks like the bone density is getting worse, this woman's at high risk for a fracture. And we know, the cost of a woman having a hip fracture. We know that the recovery, can be very, very hard. And there are other medicines available in IV forms and subcutaneous injection form. There are other treatments.
And you mentioned lifestyle changes too. Like what other than taking a pill, is there something else we can be doing?
Well, we definitely want to make sure that we're getting in enough calcium. Before menopause, probably 1,000 milligrams of calcium a day is okay. I mean, the average diet, we probably get 600 milligrams of calcium. So most women need a supplement. But after menopause, 1,200 to 1,500.
Wow.
Now, if a woman's on hormone replacement therapy, of course, that's a whole other topic we can discuss. But she probably could take 1,000 milligrams, because that hormone replacement is still keeping her bone health. Estrogen's the biggest factor in our bone health. But, you know, getting in enough calcium, vitamin D, they recommend 800 to 1,000 units a day. Although typically I don't really find that to be enough. Most women, I need to put them on 1,000 or 2,000 to really get their levels in the normal range.
And so is in a typical women's vitamin, not going to cut it? Have to take calcium in addition?
You probably need an extra calcium and vitamin D on
Okay.
top of that.
Okay.
And of course, being more active, weight-bearing exercise, very important in keeping bone strength.
And getting outside
Yeah.
for the vitamin
That
D.
helps your vitamin D. 10 minutes, 3 times a week to your hands, your face, your arms can give you adequate vitamin D.
Wow.
So it wouldn't cut it to just get out there on a Saturday.
Nice try,
Because I
Jenny.
go to work when it's dark and I come home when it's dark, feels like most days.
You mentioned supplements, menopause, supplements,
Yes.
patches, pills. Where do you stand on that?
Well, you know, it used to be, oh, you're in menopause, you're having some hot flashes, here are some hormones, see you later. I mean, I don't think we were that cavalier about them because we knew that there were risks, but definitely the use of hormone replacement has went down after the Women's Health Initiative study that came out in 2002, which followed women who were taking estrogen, a combination of estrogen and progesterone. That study did show a small but an increased risk of coronary artery disease, strokes, breast cancer, blood clots in women taking estrogen and progesterone. So we still use it. We still prescribe it for women who have very severe symptoms. There's severe hot flashes, severe night sweats, the sleep disturbance. But we use it for the lowest effective dosage for the shortest amount of time now to hopefully, and of course we screen women before we put them on hormone replacement therapy to make sure there's not a risk factor there that makes her not a candidate for that. So we still have, there's still a place for it. We haven't just thrown the baby out with the bathwater. Yes, we haven't just thrown the baby out with the bathwater, but we are more circumspect in our use of hormones.
Okay, so women, a couple of key things that I want to talk about before we run out of time here. Go to the doctor.
Yes.
Get your screenings.
Yes.
And again, it is called Better Living, so don't shoot the messenger, but it does seem like every show, every week, it all comes down to the same thing. Get a little bit of exercise every day. Get outside and walk and garden and do whatever you love to do outdoors and eat those fruits and vegetables and try to live in a healthier manner so that you can live better as well.
And go see your doctor.
See your doctor. There's no need not to get on some medicine and be compliant with your regime so that we can have you around for a very long time. Dr. Culpepper, thank you so much for joining us today.
Thank you.
Important information, and it is National Women's Health Month, so if you haven't had a blood pressure screening in a while and we have encouraged you or motivated you enough to get out there and take control of your health, there are health screens all over. There are health fairs. This is the health fair season. You'll see at many senior centers will hold health fairs. And if you're at all wondering here in Atlanta or Arizona or anywhere really, you can call us at the Homestead Hope Foundation or check out our website and send me an email and we'll connect you to a health screening near you. Again, Dr. Culpepper can be reached if you're in the Johns Creek area in Atlanta at 770-497-1555. And you can always log on to our website at www.homesteadhopefoundation.org. Stay tuned because we're going to be right back with Dr. Lisa Culpepper. And we're going to talk more about breast cancer screening, bone health, new guidelines for cervical cancer screening, and menopause and more. So we'll see you in a minute. Hello, I'm Jean Pete, and I welcome you back to our show, Better Living. Better Living is brought to you by the Homestead Hope Foundation and is sponsored by Homestead Hospice, where commitment to education and premier hospice care helps patients and families through life's most important journey. Welcome back to Better Living. I'm Jeannie Pete, and I'm here with my co-host, Allison Finley.
I'm here.
And we are back with Dr. Lisa Culpepper, a family practitioner in the Johns Creek area of Atlanta, Georgia. But if you're listening to us from Arizona or some of our other markets in New Orleans and the Gulf Coast, please stay tuned because we've got some very important information. on women's health. Specifically, we spent the last half hour talking about cardiovascular health for women. And now in this half hour, we're going to talk more about breast cancer screening and bone health and new guidelines on cervical cancer screening and menopause and how you can live better, hence our name, Better Living. So welcome back. Again, Dr. Culpepper, thanks for being with us today. Important information that we want to get out to our communities. Let's start by talking about bone health. I know we touched upon it, and you had talked about some of the different medicines that you're giving to women during menopause and some of the side effects. Can we just kind of recap that, and then we'll go into more detail about bone health?
Absolutely. I mean, not every woman who has bone loss needs medication to treat that, but for women who have the most severe form of bone loss, which is osteoporosis, they're at a very high risk for fracture in their hip, fracture in their spine, a fracture from a simple fall. So for those women, there are medications available to treat. The first line medication is still the bisphosphonate class. That there are several medications, Fosamax, Actonel, Boniva. They can be once a week, once a month. But those medicines help prevent the osteoclasts, which are cells that help destroy the bone. They basically just kind of help prevent their activity and sometimes allow new bone to be laid down. But of course, a lot of women have heard about not the controversy, but rather the side effect of there is a very low risk of osteonecrosis of the jaw, which is very serious because part of the bone actually dies. We actually see that more likely in women who are getting the IV forms of those medications, although there have been a few reports of women getting the oral. It's a very rare complication, but it is something to be aware of, especially if you're on one of those medications and you go to the dentist and you have to have dental work done. They need to know that you're on one of those medications.
Right, and you might not think about that.
I wouldn't have.
Absolutely. And of course, those medicines, some women don't tolerate them because they can upset the stomach. They're inconvenient to take because there are side effects as far as damage to the esophagus and the stomach. So there's a very particular way that you have to take it. You take the pill, you have to be upright for 30 minutes.
Oh, wow.
So otherwise, it does increase the risk for having reflux, pain in the esophagus. So that can be inconvenient for women, or if they have that side effect, they're not going to want to take it. And we certainly wouldn't want to continue a woman on medication that might be damaging their GI tract. So for those women, there are other medications available. There is an IV infusion once a year called Reclast. There are some shots that we give under the skin. Some of them there's one that's every 6 months, so it's only twice a year. One that's once a month.
And the side effects are not higher?
The side effects are not any higher than the bisphosphonates, your oral medications, but you
can... Well, heck, I'd opt for that.
But you still, with those medicines, there is still the concern about the jaw. But those medicines do seem to be better tolerated, and it's probably because you're only giving it once or twice a year.
Right.
That makes sense.
Now, with the ones that you take daily or monthly, is it something that you end up getting a tolerance to, or it just continues as you take it to upset your stomach or what have you?
I find that most women, if they have stomach side effects from it, they continue to have those. Okay. I mean, obviously, we try to avoid those with the, being upright for 30 minutes after you take the dose, but
it's hard. Yeah. So you had mentioned something in the last half hour, and that was that they were suggesting screenings for bone density at 65?
Yes.
Or maybe 60. Mm-hmm. Yet we lose most of our bone density or our bones deteriorate during menopause.
Yes.
And it's most effective to catch it those first 5 years when that's occurring so that you can protect your bone density. Mm-hmm. Okay, that's a problem.
I agree.
It's true.
I don't necessarily agree with those guidelines myself. And a lot of doctors, medicine is an art and a science, and we use our best judgment for our patients. guidelines are out there for a reason, and they're definitely important because a lot of thought and attention and studies reviewed goes into those guidelines. And most of the time, I agree with them, actually.
Right.
But when it comes to bone health, I have to say, I don't agree with waiting until a woman is 65.
Yeah, and neither do I. And so, what do we do? How can we advocate for ourselves as a patient? Because if you're a doctor and you're really held to guidelines and, maybe you're in a independent practice, but a lot of practices are connected to hospitals or what have you, and Medicare's looking at that, and we know the ins and outs of the healthcare industry as it's been in the news for at least years. What can we do? How expensive are these tests, and what if we want it and we can't get it written for us?
Well, a few things. Even though the guidelines say wait until 65, there are a lot of insurances that will cover bone density screenings in menopause. Now, there's a lot of difficulty covering them before menopause. Once in a while, I like to screen a woman before she goes into menopause if she has a very strong family history, or there are a lot of medical conditions that increase your risk for bone loss. Hyperthyroidism, diabetes. There are a lot of autoimmune diseases, a lot of blood disorders, medication use, patients who are on long-term steroids. I mean, I have a daughter who she'll be 13 this summer. She's been on prednisone for 2 years now for an autoimmune disease. I worry about her bone health. I'm not going to want her to wait until she goes into menopause to have a bone density.
Right.
It sounds like probably vastly more people are candidates for bone density earlier than people who can afford to wait till 60 or 65, just because everything you've listed, drug use, medications, and a whole lot of things that might have happened to you in your life indicate that you ought to be checking this sooner.
Absolutely. And there are, you mentioned in the previous half hour that there are, a lot of health fairs and different things that are set up. And there are various health fairs that do bone density screenings.
Oh, look at that.
So, the screening that they do is more of, a simple screen, kind of a pre-screen, but still.
That's okay.
Yeah, that's okay.
Yeah.
If it gets kind of our foot in the door, we see a little bone loss, we need to do a full DEXA scan.
And then the insurance company will cover it.
And then the insurance company should, we hope. It can be a fight a lot of the time.
Okay, so the long and short of it is, if you're a woman going through menopause and you're concerned about your bone health, talk to your doctor about it and start a dialogue and a conversation. And your doctor will probably dig for family history and other diseases such as the hyperthyroidism and diabetes. And so you may get a screen earlier than 60, 65 if you start that dialogue going and if you see your doctor.
Yes. Again, periodic health screenings are very, very important.
Okay, great. So now let's talk about breast cancer screening.
Sure.
Same kind of thing. Are we being told to go at the right stages? Because, we were having a little conversation here at the break that used to be, they said, go get a mammogram in your 40s. And now, did they move it up to 50 or am I wrong there?
Well, there has been a lot of controversy, and there was a news report about how women between 40 and 50 should not get a mammogram. The screening guidelines, which we just talked about with the bone health, this is someplace where I actually do agree. Almost from your American College of Obstetrician, Gynecologist, American Cancer Society, they say get a mammogram at 40. Next to skin cancers, breast cancer is the most common cancer in women.
And you hear about it in the 40s.
You hear about it in the 40s. 95% of women who have breast cancer are over 40. So you do run the risk of missing that 5% less than 40. But we will be able to screen most women starting at 40. There is still controversy about between 40 and 50. Should we do it every year? Should we do it every 2 years? We definitely know after 50 we should do it every single year. And you also should be going into your doctor once a year for a clinical breast exam. Self-exams, we do want to educate women about awareness of their breast. There are some groups that say, yes, women should definitely do self-exams. She might pick something up on a self-exam. There are some groups who say, they're more likely to find something that's not a cancer and then go through the endless tests and the worry and things like that. But it's pretty clear that there is a decrease in breast cancer death with regular mammogram screening. You can pick up a breast cancer on a mammogram several years before you actually feel it, before it shows up as a lump, before it shows up as an enlarged lymph node, before it shows up as redness, swelling, pain in the breast. There are lots of different ways that breast cancer can appear. And if you can catch that early, at an earlier stage, then that allows you a much greater range of treatment options. It could be the difference between having just a lump removed from a breast rather than the whole breast removed. It could be the difference between having to have chemotherapy and radiation.
It's so important. And, we don't like to go for mammograms.
No.
It is uncomfortable.
We do not.
You'd think they'd come up with a better way to fit that thing in there. I don't know who designed that thing, but...
And the nurses are always so cheerful because they know you don't want to be there.
Well, I have to tell you, I got sent a cartoon, just to digress for a minute. I got sent a cartoon on Facebook about if women were in charge of healthcare or creating these tests, how they would do a prostate exam. And it looked an awful lot like the machine that they were using on mammograms, so I got a little kick out of that. However, I do think that if somebody could come up with a better way to fit that thing in there, they could make millions of dollars. So shout out
Maybe
there
I
to
should be
some
working
developer. Try to fit a square peg in a round hole or a round peg in a square hole. It just doesn't work. However, even all that being said, a little bit of discomfort for 5, 10, 20 minutes can make all the difference in the world, because chemo, radiation, having a breast removed, a surgery is far worse than a little bit of discomfort for 20 minutes or so.
It is true. And as the genetic factor, it seems to me that people put a lot of emphasis on the genetic factor. If there's a history in your family, it's a super big red flag, as opposed to some of the other diseases we've discussed. My sister-in-law's, I think everybody in her family has had breast cancer. Her mother, her sister, her aunt, her grandmother. She literally at one point was discussing having a double mastectomy,
yes,
just so she wouldn't have to worry. She goes in every 6 months for a mammogram because she's so panicked about the whole thing. So genetics, is it that big of a deal?
I mean, genetics are a risk factor, and definitely it's something to think about. For a woman who has several family members who've had breast cancer, they need to have more breast cancer surveillance. They may need a yearly MRI. Mm-hmm. They may want to consider the BRCA gene mutation testing. But that being said, 70% of women who have breast cancer don't have a family history.
Wow.
So,
70%.
Because I hear that all the time. Mm-hmm. Women who say, well, I don't have a family history. I don't have to worry about it.
I hear that too
and
from my friends.
The opposite is true. We do have to worry about it. And, as we get older and our life expectancy increases, we have a 1 in 8 chance of getting breast cancer as we get older. We do have to think about family history. That does play a role in, we may have to go beyond a regular mammogram, but that is not everything.
And you made a good point. We are living longer. Therefore, we're opening ourselves up to having more health issues arise that a generation ago, people simply didn't live long enough to see.
Absolutely.
But, it is great because we are catching breast cancer earlier with these mammograms and other tests. If a mammogram looks funny, they go to other tests as well. And so we are doing a much better job of living after breast cancer than we did years and years ago. So screening, taking matters into your own hands, getting that mammogram, seeing your doctor, and being in charge of your own health is so important, especially for women in their mid-40s, 40s, because that's when breast cancer seems to be so prevalently diagnosed.
Absolutely. It is a cancer that, as we get older, there are some things that risk factors for breast cancer that you can't change. You can't change if you're 65. You're going to be at higher risk for breast cancer than when you're 40 or 45. As we get older, we're more likely to have it. We can't change our family history. We can't change if we started our periods early or we've had late menopause. So those are risk factors for breast cancer.
Really, if you go through menopause late?
Because it's just more time that, that you have been exposed to your own hormones, your own estrogen, and the changes that can cause in the cells. So which is a risk factor.
So what is late? What constitutes late?
Well, the average age for menopause is 51, 52, but late menopause, after 55 would definitely be a risk factor. But there's some risk factors for breast cancer that we can modify. There have been some recent studies which have definitely shown an impact on alcohol use. They say that 2 drinks or more a day can increase your risk over 21% for breast cancer.
What kind of drinks?
Wait, they were just telling us red wine is good, and now
I know. It's good for the heart, may not be so good for the breast. Obesity is a huge risk factor for breast cancer. If you've gained 55 pounds or more after you've turned 18, you increase your risk for breast cancer 50%.
Oh my gosh.
We're going back to our exercise and
a
eating
lot
our
of
fruits
women
and vegetables.
do. But in all seriousness, a lot of women have those babies and never get that weight off. And I used to be one of those
and
women.
It changes your metabolism. It does. Having a baby changes your metabolism. But then again, menopause really changes your metabolism.
So let's talk about that, because I also know, and I don't know if it's my age, lots of women in their mid-40s, all of a sudden kind of the light bulb goes off and they start exercising and they're eating better. And I've known a lot of folks, even just folks at work, who've lost 50 pounds. Seems like 45, 50 pounds. Does that decrease then your risk, or were you still at a higher risk because you had that extra 50 pounds on for 2 decades?
It does decrease your risk. It's not too late to drop the weight and improve your breast health and your heart health and your bone health. And when we think about menopause and our life expectancy is now around 80, we spend a third of our life in menopause.
Lord.
So I don't know if that's a cheerful thought or not, but
not
all these
for all the
things
people in our
become very
lives.
important to living well in menopause, and we just can't emphasize enough prevention. That's always what we keep coming back to. If there are things that we can do to at least decrease our risk.
Okay. So, folks, if you're going to get out there and get healthy, don't leave out going to get your annual or biannual or every other year mammogram. You've done all of that other work.
Absolutely.
Take care of yourself. Now, let's talk about cervical cancer. That's pretty scary. The silent killer, is that what they're calling it?
Well, there usually aren't symptoms until it's pretty advanced. As far as the screening guidelines go, and of course, cervical cancer screening we do through our yearly pap smear, which usually we start around the age of 21. We may start a little sooner if women are sexually active a lot earlier than that, but most of the American College of Obstetricians and Gynecologists and American Cancer Society say to start screening at 21. Because cervical cancer, yes, like you said, it is a silent killer. It's not going to present itself usually until it's at a late stage. So if you don't, and by that point, it can be very difficult to treat. So we do recommend getting regular pap smears. And we used to think, well, we should do a pap smear every year. It has to be done every year. And the guidelines that have come out, they're not necessarily new, but they're just kind of more emphasized that a woman over 30 who is low risk, she probably doesn't need a pap smear every year. Could actually probably go to every 3 years. And a lot of that is because we know that the cervix has become not as hormonally active. Also, now we can do the HPV testing. 95% of cervical cancers are caused by HPV virus, which there are several different strains. And of course, in our younger age group, I know we're talking about women over 40, but we do have the Gardasil vaccine, which cuts down your risk for cervical cancer, which I think is wonderful. We don't have that many vaccines against cancer.
And is that the one that they're talking about, the controversy? You can give it to girls at like 14?
Yes.
Yeah.
And now I'm hearing boys can
Yes.
take it.
Yes. Because men, it can increase their risk of certain cancers too. And of course, where does the woman get it transmitted from? From her male partner. So, as far as cervical cancer goes, we're actually finding in instead of our breast cancer and our bone health screening, where we probably need more, the cervical cancer screening can actually go to less. Because we can check for the HPV virus, we can see, well, do they have a strain that causes cancer? Do they not have it at all?
Well, that's good news.
So,
a little bit of good news in this.
little bit of good news. Don't have to do that as often, so don't be scared of coming in.
Okay, great. All right, so we only have a couple minutes left. I do want to get your contact information out there again because we haven't done that this half hour. So why don't you let everyone know your address and phone number and where you can be reached if somebody needs a mammogram or needs a doctor to take care of them in the Atlanta area.
I am a partner at North Chattahoochee Family Physicians. We are at 11459 Johns Creek Parkway, at the corner of Johns Creek Parkway and Highway 141. My office number is 770-497-1555.
And I know we've talked about health screens during this show in the last half hour as well. And if you're here in the Atlanta area, I do happen to know that at the Woody Fight Senior Center in Douglasville today, they're having a health fair. So you could go over there and get blood pressure screenings, among other things as well. And that's in the Douglasville, Georgia area. But a couple of key things that we talked about this half hour and last half hour is just get to your doctor, stay on top of your annual exams, get those mammograms done. May is National Women's Health Month, so take care of your health. You know, when the show's over, not yet, but in a couple minutes, you can pick up the phone and call your doctor and get that scheduled to get in there and take care of your own health. Screenings for breast cancer and cervical cancer, simple tests that take very little time out of your life and can help you live better for the future and have a better future as well. Anything else that you want to leave our listeners with that I might have missed?
I think exactly what we've emphasized the whole conversation that we've had here today is that we can live better. We're living longer. We can live better. And a lot of that goes back to prevention and eating healthy and exercising and doing our periodic health screens, taking good care of ourselves.
And we as women, you know, we take care of everybody else.
We do.
And
the
our
ultimate
health suffers.
multitaskers.
And that's why a lot of women do gain weight, you know.
Absolutely.
They have those babies, they're running around
I'm not
crazy.
saying it's easy at all.
But the best thing you can do for everybody else that you're doing for on a daily basis anyway is to take 15 minutes out of your day and do for yourself instead. So I'm Jeannie Pete. You've been listening to Better Living. Allison, thanks for joining me again today. Love having you as my co-host. Dr. Culpepper, I'm so glad that you came in today. Very important information was discussed for women and myself. I'm going to leave and schedule a mammogram.
Me too.
Very good.
Thanks for listening. Have a blessed day and week ahead. And listen here, same time next week and every week. Homestead Hope Foundation is your resource for a healthy life. God bless.